This talk is a summary of a meta-analysis describing the most effective nerve transfers for restoring elbow flexion after brachial plexus injury. You can find the full paper published in the Journal of Hand Surgery. After screening thousands of hits from our systematic searches, we included 64 articles. These represented 1,335 adults with plexus injuries. Most were men in their middling 20s. The primary outcome was the restoration of M4 or greater elbow flexion. In the included studies, the neurotization was performed on average 20 weeks from the injury, and the included studies had a mean follow-up of 2 years. For patients with partial brachial plexus injuries, the majority of whom had upper trunk injuries, we observed that 75% would, on average, attain M4 elbow flexion. There was a systematic difference observed between different donors, and overall, based on the consistency of the data, the amount of data available, and the quality of the studies, the double oberlin appeared to be the most effective transfer, with roughly 9 in 10 patients attaining M4 and with a low I-squared value, meaning all of the included studies reported very similar findings. Data on outcomes in patients with pan-plexus injuries was more sparse and indeed heterogeneous. Overall, roughly 46% of patients attained M4 after an extraplexal nerve transfer. Although it's tempting to conclude that the spinal accessory nerve via a graft appeared to be more efficacious than other options, this was based on a very small amount of data, and the heterogeneity between groups was very large, so we were more cautious in the interpretation of this particular data. Of greater interest was the results of our meta-regression. This graph summarizes the findings. On the x-axis is the time from injury to neurotization in each study. On the y-axis is the probability of patients attaining M4 or better elbow flexion. You can see for patients with partial, mostly upper trunk injuries, that it really doesn't matter when you do the neurotization because the blue line is flat, meaning that the probability is static over time. However, for patients with planned plexus injuries, there is a clear detrimental effect of delay, whereby each month of delay is associated with roughly 7% worse chance of attaining M4. More importantly, our review highlights some major problems in the nerve surgery literature. Firstly, we must move away from the BMRC scale. We know that this isn't important to patients, poorly represents their function, and is very difficult to handle statistically. We should be moving towards patient-reported outcome measures, things that they really care about, or at very least, continuous measures of motor function, such as dynamometry. Very few, if any, of the studies included in this literature review reported the adverse outcomes associated with neurotizations, and this meant it was impossible for us to ascertain which was best, because without knowing the risks, you can't possibly comment on how safe or preferable a particular surgery is. And given this treatment is relatively uncommon in the grand scheme of things, we feel that it is ripe for an international collaboration with open source data sharing and common outcomes. And finally, a huge thanks to my fantastic team of co-authors who made this work possible. If any of you out there listening would like to get in touch, talk about future collaborations, or give us feedback on this work, then do get in touch with me anytime. Many thanks for listening.